Dear students, dear colleagues, we continue the psychiatry education from the University of Page, 5th year, first semester, and today's topic are sexual disorders. We have started with some historical aspects. The first person, the first great psychiatrist I would like to mention is Prof, who was a professor of psychiatry at Graz, Austria, and he published a very famous book, The Psychopathia Sexualis, which first summarized in medical terms the different perversions, the different abnormal sexuality forms at the end of the 19th century. And this book is important for us today because it's really was a comprehensive and good summary at that time, and many disorders which were described by Krafft-Ebing at that time still in the classification systems of recent books. The other reason that I mentioned this book because it's interesting that this book is not only a part of the history of medicine, or not only a part of the history of psychiatry, but this book is, we can say, a part of the history of erotic literature, or history of pornography. Why? Because when this, the first edition of this book was published, by the legend we know, this book was not only read by medical scientists, by psychiatrists, by physicians, but this book was also used in bordels, in places where prostitutes had worked, and they put this book into the brothels, and the clients read this book. The clients used this book as a instrument, as a tool for developing sexual excitement. And when Professor Krafft-Ebing realized that his book is not only used for medical purposes, but it is also used in pornography and industry, then he replaced the original German terms with Greek and Latin forms, and this led to the introduction of Greek and Latin terminology in the field of sexual pathology. The other historical aspect, and another great psychiatrist I would like to mention, is Sigmund Freud, who, as you know well, in psychoanalysis, see the sexual drive, the libido, as a very important organizing principle of the personality development and the personality. And you had learned from medical psychology the psychosexual development to a theory of Freud, the oral phase, the anal phase, urethral phase, the phallic phase, which are autoerotic phases of sexual development, and the first heteroerotic phase, the Oedipal conflict, the Oedipal phase, when the young boy, as Freud said and believed, develops sexual desires towards the mother, towards the opposite sex parent, and develops anxiety and fear from the same-sex parent, the father, and this is what, after the Sophocles drama, Freud called the Oedipus complex, or the Oedipal phase. And this kind of idea, the development of the sexual drive, was very influential in dynamic psychiatry, and we should mention this, and the understanding of pervert paraphilic sexual activity by Freud was very much influenced by this developmental theory. Here you see the English edition of his famous book, The Three Essays on Sexuality, the Three Essays on the Theory of Sexuality, where Freud described and summarized his viewpoint on human sexuality and psychosocial development. And in the previous slide I forgot to mention, and it's important to have a look at this caricature where you can see that what's on the man's mind, and you can see a head of a male person, and the forehead and the nose and the face is what you really see is a naked woman. which somehow in a caricaturic way expresses that Freud was very much overwhelmed with the importance of sexuality in human life. Okay, if we turn our attention toward sexual disorders, then we can say that in modern classification systems, sexual problems, sexual disorders can be differentiated into three groups. The first are sexual dysfunctions. The second are paraphilic disorders, which the previous term, the old term, is perversion, and gender identity disorders. In sexual dysfunctions, what is important, that the patient has a problem, has a dysfunction with normal, culturally accepted sexual activity. So the patient do not have abnormal sexuality, but some parts, some phases of human sexual intercourse is disturbed in these disorders. We shall see the details. The second are paraphilic disorders or perversions, then culturally, recently not accepted abnormal sexuality forms represent the patient. And the third group are gender identity disorders, when the patient, as the term expresses, has a problem with his gender. The patient has an anatomical sex and the patient has a psychological sex, and there is a discrepancy between the two. We shall see the details in the next minutes. Let's turn our attention towards sexual dysfunctions. You know that human intercourse has four phases. The first is desire, wish for sex. The second is excitement or arousal. The third is orgasm. And the fourth is resolution. And these four phases can be disturbed in sexual dysfunctions. Let's see these. The first disorder group is disorders of sexual interest, or the sexual wish, or the sexual desire, which means that the patient doesn't have enough desire in most of the cases, or too much desire comes up. We shall see the details in the next slide. So these are the disorders of sexual interest, and most of the cases the patient has less sexual interest than normally it is accepted. The other group are the disorders of sexual arousal. We know that in the case of males, the arousal phase means erection, and in females, the arousal phase means vaginal lubrication, and these are disturbed somehow, and these disorders are put in this group of disorders. The third are the disorders of sexual orgasm. In the case of females, it is anorgasmia, when after a normal excitement phase, normal arousal phase, normal vaginal lubrication, there is no orgasm. This means anorgasmia. Or ejaculation disorders, as early or retarded ejaculation, as we shall see later, come up, and we will deal with this in the next minutes. The next sexual dysfunction are genital pelvic pain and penetration disorder. This previously was called otherwise, but it's put together in the DSM-5 now. Dyspareunia means that there is a pain by the female during intercourse, and vaginism means a constriction of the vagina during sex. Sexual dysfunction due to general medical condition, it is also important because in the case of chronic illnesses, or in the case of cancer, in the case of illnesses with serious pain, there is in most of the cases a decreased libido, a decreased sexual interest, a decreased arousal, erection problems can appear. So this is also a problem we have to know about. Substance and medication-induced sexual dysfunctions. What we see in the case of some substance-using individuals, that, for example, heroin addicts stop having sex after a time, not all patients, but some of them, or medication-induced sexual dysfunctions. There are some medications which leads to sexual dysfunctions. For example, in the case of females, SSRI antidepressants can lead to anorgasmia, or some antihypertensive drugs can cause erectile dysfunction, erection disorder, so or other forms we shall see later. There is another group which is called other specified sexual dysfunction. Here, with a question mark, you can see hypersexuality. Previously, hypersexuality as a disorder of the resolution phase was known. In the DSM-5, it was excluded, but we have to know that the hypersexuality forms. In the case of females, it is called nymphomania, and in the case of males, it is called satyriasis, when there is an increased sexual interest and continuous sexual interest after orgasm. And Casanova is a famous person from history who we know that were hypersexual and was extremely increased sexuality was characteristic of that person. And there are unspecified sexual dysfunction, there are so-called some anxieties around sexuality, and what we know from literature, it is called the small penis complex, where the male has a kind of fear, has a kind of anxiety that his penis is not enough big, and this is called the small penis complex. Okay, let's see a few of the disorders of sexual interest and arousal. The first is hyperactive sexual desire disorder, where you can see two illnesses as male hyperactive sexual desire disorder, which means that the male do not have normally accepted interest in sex. The male can tolerate having no sex for long months or for years. Or the other one, female sexual interest and arousal disorder, when there's a lack of interest towards sex and problems with vaginal lubrication during sex, and this is was put together in the DSM-5, and nowadays it is called female sexual interest and arousal disorder. There was an illness which was previously in the classification system, and now it was excluded from the DSM-5, but you have to know about it, sexual aversion disorder, because this means that somebody resists having sex in all forms, and in many times this is an existing problem, this is an existing disorder, and this many times is connected to rape history, that previously the patient was raped, the patient was sexually seriously abused, and this leads to a total rejection of sexuality. And the last one in this slide, which you see here, is erectile disorder, or the classical term is impotence, which means that the male patient has problems with erection. It's important to mention here that if you hear a lecture on erectile disorder from urology, maybe you can get a different point of view if you hear a lecture on erectile disorder from the psychiatric point of view. Because some doctors, physicians, somatic doctors, tend to see erectile disorder more from an organic perspective, more from a somatic perspective, and others, psychologists or psychoanalysts, tend to see erectile disorder more from a more from a functional or psychological point of view. Both can appear, both can be true. But we know from great epidemiological studies that if you see all patients with erectile disorder, then about 70% of patients has an organic background, and about 30% of patients has psychological background. And we can highlight two typical patients. The first patient is 60-year-old, has hypertension, obese, smoking, using antihypertensive medication, and this is one type of patient who most probably is an organically based erectile disordered patient. And we can see another patient who is 20-year-old, healthy, a university student who had some experience with sex but has some failure having an erection because the patient drank too much, or the patient was anxious, or the partner was not cooperative, and so on. And the patient had a problem with erection, and after a time the patient develops an overwhelming anxiety whether he is a male or not, whether he is a good man or not, whether he is impotent person or not, and this leads to increasing anxiety, which has a bad effect on the next sexual experiences. So these are the two types of patients we have to differentiate. In the case of the second patient, the psychological factors are important. In the case of the first patient, the organic problems are the important. And also other disorders of sexual orgasm, female orgasmic disorder, which means that the patient has a normal vaginal lubrication, normal arousal phase, normal excitement phase, but no orgasm is coming. It can be a side effect of certain psychopharmacological agents that I have to mention are SSRI antidepressants, selective serotonin reuptake inhibitors, can cause this side effect. So if you have a patient with depression, and the patient, a female patient with depression, and the patient is improving by the usage of SSRI antidepressants, and after 2 months or 3 months, the patient starts to say that he would like to stop the medication, and the patient is not willing to tell why. The patient improved in the terms of depression, but the patient starts to reject the usage of medication towards, then you can think about that maybe there is a sexual dysfunction, and the physician, the psychiatrist should directly question this, whether do you have any problem with sex or not, because if it is open, you can explore this, then you can discuss this with the patients. There are some ways to treat this, so there is possibility to continue the SSRI medication and reduce the side effect of anorgasmia. For example, a simple technique is to use drug holidays, which means that the female uses the SSRI antidepressant during the week, and Saturday and Sunday the patient does not take the SSRI, and this can reduce or can decrease the side effect, but the therapeutic effect, the SSRI, remains there. Delayed ejaculation and premature or early ejaculation are two male orgasm problems. Delayed ejaculation also can be a side effect, for example, antipsychotics. Some antipsychotics, typical first-generation antipsychotics, can cause this. And premature or early ejaculation can be connected to too much masturbation during adolescence, and this can be a cause of premature ejaculation during early adulthood. In the treatment of sexual dysfunctions, we can promote, we can advise, we can recommend this anon-plicit model, anon model, which is called the plicit, which means that dealing with sexual dysfunctions, you should establish a permissive atmosphere for the patient. Everything is accepted, no moral judgment, and in a permissive way you can approach the patient much better. Limited information is needed, that you only have to say to the patient what is really needed. You don't have to teach the patient the whole Freudian sexual theory, because maybe the patient will have increased level of anxiety if he starts to read that Freud spoke about impotence as a sign of erectile dysfunction, spoke about erectile dysfunction as a sign of latent homosexuality. So if the patient is very much Freudian and suffers from anxieties around erectile problems, then maybe it can worsen the state. So only limited information. Tell the patient what is really needed. Specific suggestions, some specific techniques. I also already mentioned that in the case of female anorgasmia, which is caused by SSRIs, maybe you can use the drug holiday technique to reduce the side effect, and the good effect of SSRIs remains. And also there is another technique, the so-called squeezing technique, which can be used in early or premature ejaculation, where you can recommend the patient that if the patient feels that ejaculation is coming too early, then he can stop having intercourse squeeze the gland penis with his thumb, and when the feeling of ejaculation disappears, then the patient can continue having sex. So these are simple specific suggestions. And intensive therapy, which means intensive psychotherapy, it means that if there is a psychotrauma behind, there is a rape history behind the sexual dysfunction, you can, with psychotherapy, with intensive psychodynamic psychotherapy, you can deal with this. The other second group of sexual disorders are paraphilic disorders, which means a kind of sexuality which we see recently as culturally abnormal. And I have to say that this has many ways changed during the previous decades or the previous centuries, because if you open the book of Kraftewing, the Psychopathia Sexualis, there were many so-called perversions, paraphilias, which nowadays we do not consider, do not see as paraphilias. For example, fellatio, which means an oral genital contact, recently is not used, not called as paraphilia. Cunnilingus, also oral genital contact, is not seen recently as paraphilia. These are parts of the normal foreplay, and in the 19th century these were seen and interpreted as perversions or as paraphilias. So there are many changes here, and I suppose that there will be some changes in the next decades in the field of paraphilias. Let's see the most important ones. Exhibitionistic disorder, which means that the patient does an exhibition from his genitals. The patient, typically male patients, show their genitals to women and to shock them. And the women typically run away and starts to yell, "What do you want from me? Why are you doing this to me?" and so on. And the patient is very much excited by this shocking effect. So the patient shows his genitals. This leads to a shocking effect. The female fade away and run away, and the excited patients does masturbation, and this is the classical form of exhibitionistic disorder. The next is fetishistic disorder, where the patient has a special interest in certain fetishes, certain objects, for example, pantyhose, or certain shoes, or special types of objects are needed very much for the patient to develop a normal erection, to develop a normal sexual arousal. And without these objects, there is no sexual arousal, no sexual interest. So these patients who really suffer from fetishistic disorder many times do not find partners, because average women are not willing to be part of this story, and most of these patients visit prostitutes and dress them into certain objects and use these prostitutes to satisfy their needs. Frotteuristic disorder means that rubbing against the body of a female, unwilling female, for most of the cases in buses, the patient gets on a crowded bus and pushes his penis in the crowded bus towards a woman, and this leads to sexual arousal. The patient takes off, goes home, masturbates, and then repeats the sexual activity again and again, and it leads to this disorder. Pedophilic disorder, the most important paraphilia, because pedophilia means, as everybody knows, having sex with children, and it's very harmful, it's very damaging, and it's very, very great problem in society, because these pedophilic individuals can cause very serious harm, very serious psychological and sometimes physical harm on young children. And we know in modern psychiatry that eating disorders, psychosomatic disorders, treatment-resistant depression, dissociative disorders, personality disorders, sometimes psychosis, are related to pedophilic activity by adults on children. So we have to prevent this, and it's very important to fight against this activity. Sexual masochism and sexual sadism disorders, which means that causing of suffering in sadism and suffering in the case of masochism leads to the arousal in the patient. And these individuals are in pairs. Many times sadists find their masochistic partners, and this can be seen in their sexual activity. Transvestic disorder, cross-dressing, when the patient cross-dressing, typically male patients cross-dresses into female clothes, and this is used to develop an arousal in the patient. Voyeuristic disorder, the peeping Tom effect, the seeing of others having sex, which leads to sexual arousal, sexual excitement, is also a paraphilic disorder. We can mention here in the voyeuristic disorder that if we follow the idea of Freud, we can say that there is an industry which is built on voyeurism. What is this industry? I would say this industry is pornography. The reason that pornography gives huge amount of millions of dollars every year is that everybody inside has a small voyeur, and to imitate Freud, who said that the child is a polymorphic pervert individual. Everybody has a small voyeur inside, and this is why pornography is so popular. So, but in the case of voyeuristic disorder, this is different. Voyeuristic disorder individuals search for real pairs who have sex, and they try to see them during intercourse. And there are other specific paraphilic disorders, as telephone scatologia, which means that the patient with this paraphilia calls a woman, starts to speak dirty things, and masturbates during. Then there is a computer version of this, you can see. Computer scatologia, which is not in the DSM-5, but it was described in 2000, so it's a recently described paraphilia, internet-related sexual harassment in chat rooms or during email, Facebook. The sexual molestation, the sexual harassment of others is called recently as computer scatologia. So telephone scatologia described in the 1960s, computer scatologia described in 2000, new forms of paraphilias which you do not find in the crafted book, certainly. Necrophilia, which means having sex with cadavers, it's very bizarre, but existing and rare phenomenon. Zoophilia, having sex with animals, also called animal sex or bestialism. Coprophilia, playing with the feces of the partner. Urophilia, playing or drinking the urine of the partner. Clismaphilia, the sexual juices which are interested by the patients, and partialism, which means that the patient has a partial interest towards certain parts of the body, for example the legs, which is called leg erotism. This is partialism. Okay. And the third group is disorders of gender identity. Here we can mention gender dysphoria, which is the recent term for transsexuality in the DSM-5. In the DSM-5 it is called gender dysphoria. In the ICD-10, in the International Classification of Diseases, the WHO system, it is called transsexuality. Previously it was called transsexuality, and in everyday language this is the term which recently is more used, which means that the patient has a feeling that he relates to the opposite sex, not to his anatomical sex, but to the opposite sex. It can appear in childhood. Many times it appears around the age of 5, and it is suppressed, repressed by the parents, suppressed, repressed by the teachers, and later it can come up much later during the adolescence or adulthood. So these are the versions. And in transsexuality, what you see that this illness, this problem, this gender dysphoria is very difficult to be treated problem, and these individuals try to get a surgical solution for the psychological distress, and they are requesting operation to turn them towards the opposite sex. And we know that there are plastic surgery solutions for this, and what is needed here is a very careful differential diagnosis. Because if we give the diagnosis of gender dysphoria to a person, and much later it becomes clear that it was not a gender dysphoria, but it was a personality disorder, and the identity problem, the gender identity problem, was only a symptom of a personality disorder, and the personality disorder improves, and the patient discovers 10 years later that he wanted to again have his original sex, his original gender, and the operation was done, it can be a very serious trauma for the patient, and some suicides appeared because of this. So we have to very carefully give the diagnosis of gender dysphoria or transsexuality to these patients. So with this I would like to thank your attention for today, and I try to give a summary on sexual disorders during the lecture series from the University of Pécs. Thank you very much.